Sarah, was anyone else from your team join in? Nicole, I see you're here. And Tracy is here. And Tyler.
Hi.
I think we're good to go. We can get going, and if others join in, that's fine. And good morning, everyone. Thanks for taking the time um, to view some of the risk assessment tools and processes that Sarah and Nicole and Tyler is going to discuss today, particularly DEMIS. And Sarah, I'll probably turn it over to your team. That way we can have time. Nicole, I'm not sure who would be presenting the risk assessment tool.
May I just offer a couple of comments before we get started? Thank you, Safsa. Hi, everybody. Tracy Wodach, the other co-chair of this committee. Um, I do want to emphasize, we tried to clarify it in the email that we sent out, that after our last healthcare safety workforce work group meeting, there was a lot of concern from the members that we wanted to repeal the mandates of some of the intake screening, the lookups, et cetera, and not replace it with anything, and to now look forward to some solution where we might be able to put something in place that would be acceptable by all as a positive recommendation. So we're very thankful for Demas doing this research and bringing this forward today as a potential option. So really look at it um, from the lens of, if we do repeal section one, section part of it, all of it, whatever we make a recommendation for, is this a tool and option that we might be able to replace it with? Thank you.
Thanks, Tracy.
So, hi, Sarah Gadsby. I'm actually here with Julene Gerard and Tyler. Julene, I can start. Tyler, I can start, and then please feel free to add anything that I may have missed. But as a group, we got together. I know there was initial ask to share our screening tools that we do at Demas, and felt like it may be the screening tools that we used, one, are primarily used by usually licensed clinicians. There's a lot of area for clinical judgment, and it really wasn't a short and brief tool that I know that you have consistently kind of raised as a concern and needing for your different organizations. So after we did thorough kind of review, we also reached out to our medical director of the state and forensic department to really try to get some feedback from them on different tools. Some of them, again, were very comprehensive and needed really a strong mental health background, including licensure, in order to complete. So we found a tool that is currently being used in Canada by home health agencies that also has some validity and screening attached to it. One of the reasons we thought that this may be a tool that you would want to look at and consider is it's an online friendly user tool. You could actually go online and the screening will it will kind of populate based on the information that you put in. But in addition to kind of really looking at what they identify as behaviors that should be reviewed that indicate there's going to be an increase in risk, it then, just within the compass of the tool, comes up with a low, moderate, and high score. And then also gives some types of interventions that may be options. So it's kind of it's a small tool. It shouldn't take long. It kind of gets to some of the main points. But again, I think we had stressed before that risk is fluid. It really significantly can change from a day-to-day basis. And I think that's one of the highlights that we wanted to bring to the group is that you could do a screen at intake, but somebody could look much different, especially, and I've been doing community work for 28 years now, all in mental health. Myself have gone into people's apartments and have been placed in situations that were probably not the best. Substance abuse is really, really a strong indicator. So if somebody's using all bets are off. The screening tool is really null and void because it really diminishes people's ability to regulate themselves. So that's kind of where that's how we came up with the tool, really trying to look at those different areas that had been brought up by the work group through the meetings that we've had. Any questions? And actually, I should say, Julene, and do you have anything to?
No, you covered it, Sarah.
Okay.
It's interesting that the tool that you were able to find and put before us today is from Canada. For those of you who may not be aware on the call, since the murder of Joyce Grayson, we have been in touch with several safety and violence prevention type companies who offer different types of programs, safety initiatives, devices, things like that. And two of them we've partnered with several of them, but two are from Canada. And specifically because Canada has a very robust lone worker program and law requiring similar things to what we're looking at, but we're talking about all types of lone workers. We're talking about construction workers, not just healthcare. So they have a very specific lone worker law, which I think probably the information that Sarah's putting forward is helpful for the healthcare field, especially knowing that Canada's been doing, I think their law went in place some 20 years ago. So they really do have it probably fairly well refined. And from all discussions I've had with the business companies that I've talked to, they really have refined their processes for hopeful prevention, minimally mitigation. Terry, see your hand.
Thanks, Tracy. I just wondered for our discussion today, will someone be talking in more detail about how this is actually implemented? When is this done? How frequently is it done? Who does it? Who is responsible for reviewing it? Just sort of a lot more details about actual implementation, I think would be helpful.
I think it's very good. I think we can make recommendations. This obviously isn't a tool that we created, but it looks like the tool is designed that it would be really when there's a change in presentation where you're concerned there's an increase in risk. That's an opportunity where you could redo the assessment. And then based on the outcome, it would really be internally to the organization about what are the safety steps that you're going to put into place when you have somebody who's at heightened risk.
Some of the things that Sasa and I have talked about are at start of care and at various time points, our usual time points that we have in home care and in hospice, which are our reorder time, our time to recertify every 60 days. And then, as Sarah said, I think we would probably need to put some type of clause in there regarding change in behavior or presentation. I don't know how we would want to word it. I like what you said, presentation. But looking at some kind of time points so that if there is a change, we're looking at it again and not assuming that risk remains the same.
And what do you, maybe we just don't know, but like what would be the source material for history of violence? Is it just what you observe at the time that you are doing the step that you're taking? Is it what all would be included there?
Terry, I think that's a great question. And in some conversations that I've been having this week also, some with Tracy, some with others who, similar to Sarah, work in this industry, right? And a few things that we would have to define, I think also, what truly, what are we going to recognize as violence along the way? What are we going to call violence? Is it the person who is verbally saying they have an intent? Is it the individual? So to define violence in the community, that would be a good thing, right? And then along the way, we have some situations where a nurse might go out every 60 days only, right? And you only have a CNA in a home for those caseloads. So we have to figure out how all personnel that might be in the community and in a back office that might receive a call from someone that appears to be headed in the direction of a safety risk. So I think everyone should be able to, at a minimum, do a violence risk assessment, even if it's a call. This is how the person appeared on the phone, and now we need to make sure that those going in the home receive that information from a receptionist or whoever might have took that call. So we want to make sure it's a tool that everyone can have access to. We don't want to limit the timeline for when it can be utilized. If you at initial, it's done. And then if the next visit, the next nurse feels as if, or whoever is going in, wait a minute, something's off, they should have that tool readily available to utilize, and it should be a point of reference. But then to also make sure that we know that we can't predict violence, right? It's very hard to predict who is going to be violent. Sometimes the person who's going to be violent within an hour was the quietest, calmest individual. It's not always the people who are making the most noise or appear disruptive that's going to be violent. So this tool, while it's here to help us in certain situations, it's not for all, right? We're still going to need to utilize the workplace safety core competence. We're still going to need to look at certain diagnosis. We're still going to have to look at substance use. And it brings me to a few things with the current mandates and how to err on the side of safety. So a history of violence, okay. History of if they've been on the sex offender registry or impacted by the justice system. But what I'm hearing this week is that we cannot always predict which individual or which households might result in a violent situation. So the risk assessment is wonderful. I like the risk assessment tool, but I also would like to take it a step further, Sierra, and I like the protocols that DMIS have in place. I like what happens after we recognize that someone might be at risk. I like the steps that DMIS currently take, where it's kind of like, we recognize it, there's a slow approach to doing something. And then once we're in, the next zone, we're upping our interactions and bringing in others in the community and collaborating. And then there's that last level where now we're calling the police and we're bringing everyone else in. I love your no hero policy, and I think it's needed for all to know. Don't think that, oh, I built a rapport with this person, and yes, they had this issue with the other nurse or aide, but I have that rapport, so I can go in. And we want to make sure that the leadership within agencies also realize that once there is an issue, no heroes there. You can't go by rapport or say this next nurse went in and didn't have this issue, so continue to send that person. And another thing I want to make sure with the risk assessment tool is that we're not going to penalize personnel or team members when it appears like they got it wrong, right? Because like you're saying, I can do the tool now and we have no idea, they may get an eviction notice, and things can change pretty quickly for someone. It can be anything, right? To create or trigger violence. So I love that you're also showing us the tool, looking at the circumstances which might trigger violence. And I like the fact that Demas is requiring a training for community providers. I think it's a 3-day training. And so all along when I said, but then what? Then what? I feel as if we need to make sure we have a routine in place similar to what other state agencies are using. And I like the tool. I like the fact of getting information prior to the nurse going. I like the assessment tool for all to have. I like the zero hero policy. I like the steps that we take after we triage. And I like the fact that you have a training routine for all across the board. And yes, it's going to take time for home health agencies to get that training or get some kind of training, but it seems as if it's really needed. And I'm beyond the optional point. After reading all that you sent and hearing what you have to say, it's needed. And I learned something else this week, that while some of us as providers might do things the right way all the time, we can't regulate what's going on in other agencies or predict what's happening in other agencies. And one sure way to make sure that it's across the board in every corner of the state is to make sure that we have one minimum way of doing things. And I think the way that Demas outlined the approach from start to finish is a great minimum way to start, if that makes sense.
Terry, does that also answer your question regarding the definition of violence?
It's all very helpful. I just think probably lots of questions from our clinical and other folks about implementation, and I think worthy of additional discussion, and also, receiving additional information from referral sources is going to be critical to this.
Yeah.
Which
Terry,
Sasha said as well.
yeah, and I'm thinking, I remember when we had the provider call and we questioned, why would domestic abuse be there? Why would substance use be there? All of those things. Well, it's all situations which can end up pretty with violence in a home.
Trigger, yeah.
And if we're sending individuals in a situation, we should all know, we would hope that teachers would know that, there's a situation that can end up coming into a school or a daycare. And I think the same thing. I think I see the rationale now for the intake process. It actually makes sense because someone with substance use, we know in psych, they can sometimes do things and not even know they're doing it. And we know the history of violence. We know the sex offender registry. We know the fire alarm is needed, right? The smoke detectors, because someone died in a home. So I see where it's all needed, and it errs on the side of safety. And so that's my stance at the moment. Sarah, I have a question for you as far as Demas. During the last meeting, I asked which state agency would step up to kind of help with the resources. And I understand that sometimes resources don't come in a monetary way, right? The training that you have for the Demas staff, I think it's called CSS.
Yes, the community safety strategies. Yeah.
How often does Demas run those trainings? Is it only for Demas employees? And is there a possibility for home health agencies to kind of like share that process?
It's a very good question, but not one I'm going to be able to answer for you today. It is held monthly, though, to answer the question that you did have. And the 3-day, given that the 3-day that we have here is also for inpatient, so it isn't just for outpatient. So that's why it's so long. So there's parts of it that may not apply. They purposely, I think, as we onboard new employees, we have some employees that are interested in working both in and outpatient, so everybody's trained, and then it goes down to a yearly refresher, which really focuses on the outpatient model with the verbal de-escalation and looking at safety strategies, community self-protection skills in particular. But DEMAS has done like their own, they actually look at different models and have been looking at new and different models as they're trying to just stay current with more evidence-based strategies and interventions. So the reason I bring that up is, of course, it costs money, right? So it's, those types of, if we want to use the material that we've identified, that the department would have to pay for it in order to get our staff trained and then be able to use it ongoingly. So I'm not able to say whether, I'm sure that's a lot of people, I'm assuming. Sasha, how many staff do you estimate that would need to be trained across Connecticut?
I would say close to 10,000. So I think that's
A lot of resources.
It's
Yes.
yeah, although the training might be really good, I don't foresee that as a reasonable solution. I'm not sure how we would approach that. Sasa and I earlier in the week, what's today, Thursday? Yeah, earlier in the week, we talked about actually looking at Section 2 of the bill of the law that passed that addresses the training and just keeping it as it is versus going with that mandated training that we had talked about in the report prior. So I'm not sure, and that puts a mandate on each agency to ensure training that uses a curriculum that references both OSHA and CDC NIOSH standard training, incorporates it in, but it doesn't say specific amount of time. It talks more about those training programs that CDC, NIOSH, and OSHA have, and make sure that we're referencing them in our trainings and that it's annual training. So the last I knew, I thought that's where we were probably heading, and not to add something in. I don't mean to have this discussion. Sasa and I probably should have talked about this ahead of time. But I don't foresee a 3-day training for all staff, visit staff. It's just not doable.
Well, I primarily meant definitely the behavioral health, the individuals who are providing behavioral health services. I think at a minimum.
In place of like your original recommendation for that certification program, you mean?
Yes, something to consider. Let me see, Kim?
Yeah, I'm sorry. I feel like I'm getting a little bit confused about, are we talking about training on the tool? Is it 3-day training or training, the big training that we were talking about? Yeah, okay. Is it 3-day training? I assume if there's 10,000 folks that need to, get, this training and skill set, I think, realistically, you have the cost, but can we do trainer of trainers? Can we prioritize? How can we get it in there? you know, obviously, like with the implementation of anything new, there's a surge in the beginning and then it's maintenance. So I think, you know, if we could think even creatively about different ways we could handle that surge so that we could manage it, and it's not like 10,000 people tomorrow need to do it, I think is great.
What do people think about Sasa's recommendation that this be for those that serve the behavioral health population? And I would think primarily it would be for the nurses. Um, if we, because that is what originally we had talked about on that ADA, ANA certification piece, that it would be for the behavioral health nurses.
Sierra, I have a question. Tracy, 1 second before I figure out that part. Do you only provide the training at DMIS to the nurses? Because I remember when I worked at DMIS, I had to sit through this and I wasn't a nurse at the time. So was it only for nurses or anyone who might come in contact with your behavioral health population?
It's anybody that provides services in the community.
Okay. So I think
Anybody that's, all of our work is supporting individuals in their homes.
whether or not, well, you're DMIS, so they're gonna have, is it whether or not they have a risk of violence, or do you provide this level of training to all going into the community?
To all.
So
And
I
then
like-
the refresher course that you were talking about, what is that a standard training as well, or do you do that each year based on trends or situations that might have occurred, use it as, like case scenario training?
No, all the staff are trained yearly. It's required that everyone gets it, the update yearly. But obviously, just kind of given the work that we do and that we work in mental health, if there's, risk that's been identified, we have team meetings and we talk about them in the morning. So before anybody goes out, we're talking about what's the risk issue, what can we do to look at mitigating that risk for the client and for the staff that's involved. So we have organizational frameworks within our day-to-day operations that look at mitigating risk on a day-to-day basis. So it's, like I said, it's fluid,
Yeah.
it changes. So
Yeah, best
Yeah.
practice. Yeah. And how long is that annual training?
the annual is 5.5 hours or 5.25.
Stephen?
Yeah, I would second Kim's logic. I think that really resonates with me. And I'd also ask if the chairs could do me the favor of resending the bill as passed, the law statute, so I can just place section 1 in of it in context. I'm sure it's already been sent, but it's probably very far down in my inbox at this point. If you could just resend that, I would greatly appreciate it.
Will do. Thanks, Stephen. Barbara?
Thank you, Sasa. I'm just curious, as the recommendation is being made, are there thoughts about how, and again, Sasa, I appreciated your comment at the very beginning of these remarks that there are limited resources. But I think it would be important to identify in the recommendation, if this is the path forward, how it's anticipated that is it the responsibility of the individual person, or is it the responsibility of the agency, or are those costs expected to be covered in other areas? I think that would be helpful in the report as the recommendations are contemplated. That's always a good point to keep in mind. Thank you.
Thanks, Barbara. I think that makes sense. And Sarah, once we hear from DMIS about this, that would make sense. But I think agencies would take the lead here to make sure it's the way we take the lead with everything else, with training and background checks of our staff. So this is a part of it. We have to do all the DMIS required, DPH required annual trainings for aides and everyone else. So I think it's a part of our core onboarding and annual.
I have to say that we're going to need to really look at this because that's an extremely large volume of training, number of hours, um, administrative costs. I don't know that everyone will agree to this, and I know you're looking at behavioral health primarily. I'm just trying to figure this out, and it would be an insurmountable cost, I think, for many agencies.
Well, Tracy, I'm hoping that when we hear from Sierra and Demas, that there's a way. I know like Hartford Healthcare, they have the mental health first aid for free that anyone can sign up for. I'm hoping that the agencies won't have a high amount of, as high as we're hearing all of time, especially with Sarah saying we wouldn't have to get in on the intake, the inpatient side of this, some of this training. So I think it'll be good, Sarah, please, if we can hear a little more, and then just seeing if there's any commitment from Demas to, similar to how we did the CHW training with CHN and some home care agencies where we could sit in, we had certain amount of seats, similar to the MAT training or the medication certification training. We could sit, we had certain amount of seats that we could use and it could phase out over time, like Kim is saying. So not all, but we would have time to say, okay, at least the primary care nurses would have room to sit in, some of leadership. So maybe a blend, I'm not sure, but I'm hoping it's not a cost to agencies. That's going to be through the roof. Eric.
Yeah, I just wanted to make sure that I went on record saying I totally respect everybody's different lens, but I definitely support the objectives of training that meet certain criteria because those are really I mean, but I also I don't align necessarily with the construct that the training that Demas does is actually applicable to everyone and from all the different lenses and service types and our organizational structures and how we apply that. So I just want to make sure that, I just voiced that that's not, I don't want that to end up that recommendation. I fully, though, align with the fact that we should make sure that all of our in-home workers actually have education, but we have to prepare for the people that we serve and the specifics. So, for instance, if it's a behavioral health training, then as you look at listen, so much of what we do in even in the acute care transition is actually respecting the behavioral health challenges of the folks that you might not say are actively being treated. I need the ability to actually customize my training to make sure that it really actually targets the population I'm serving. We have to regionalize it, and we have to give the agencies the flexibility to do that. Thanks.
I hear that, Eric. And I also know that within our, I believe Barbara probably can speak to this, but I believe it's within our state regulations for home health and hospice that we are required to ensure that whatever services we provide, our staff are trained appropriately to be able and deemed competent to be able to provide those services. So it is a requirement within our regulations. How we go about that, like I can tell you that I know Alara Caring, who is the largest behavioral health provider in the state, has a very specific training for their behavioral health staff. And it's one that they've been using and they refine it all the time. So I think they may also feel the same way that Eric does, even though they're not on this group. But I think we need to consider that maybe it's an option, maybe not a mandate, maybe an option as a good resource. I think we have to consider that. Lauren. Oh, where'd she go? Oh, we're not hearing you.
I don't see her. Yeah, I don't see Lauren.
Lauren, I see you, and I see you working on it. I'm going to go to Kim if that's okay, and then you work on your sound. Okay, Kim.
Yeah, I just wanted to kind of circle back to the recommendations that were in the initial report that had in there something like if you were trained at one agency and then you moved to another agency, you wouldn't have to repeat a training. And, I strongly mentioned last meeting that, I exactly what Eric said, every agency should be individualized for their patient care population. So I think that if we continue to acknowledge and honor that every agency is thinking about what their special population needs and has that individualization for their agency. How are you balancing that with the need to provide a uniform training at low cost? That, like it's right there, right? So we're talking, are we talking about two different trainings? Are we pulling that apart? So I'm just holding that in my head because through this discussion, I think that, we're saying one thing and then we're saying another thing. And like, we kind of have to figure out, where are we going forward? Maybe it's the same, maybe it's different, maybe it's the same. I don't know, but.
Lauren, did you get it
Can
set?
can you hear me now?
Yes.
Oh, good. I think Sasa's recommendation is great that, there's representatives from each agency who could go to the training and then disseminate that information to the rest of the agency. I would hope that this wouldn't be a cost to the agencies with the state encouraging and asking for this, that they would be the ones to pay for this training. And I think Eric's point as well is a good one about, having some room to make it individualized, like behavioral health, hospice, things like that. I think that's good. But I think having a resource for the clinicians for education would be a great one.
So like a train the trainer option is what you're
Yes.
thinking, Lauren.
Yes.
Sarah?
No, given what everybody has been saying, I just wondered if the committee would consider looking at different vendors that actually provide safety training, because there may be vendors out there that have products that really are that would meet the needs of your agencies. So it may be more geared to working with people in hospice or the nurses going out into the homes. Obviously, we're very behavioral health, and we do a lot of like the inpatient and the outpatient work. But when we were looking at maybe making improvements in our own CSS programming, we reached out to different organizations to see what type of tools were evidence-based and what different parts of the country were, actually of the United States, what we're using. There could be vendors out there that really speak to the work that you do, and that could it's just an option. And our model that we currently utilize is what you guys are already been talking about, which is a train the trainer model. And that's how and then we have a training department that pretty much supports all of DEMAS.
Yeah, that's why
there could be much better tools out there than what we have that meet your needs is.
Understood. And that's why at the beginning of this meeting, I had said that the last Sasa and I we talked about reverting back to that section 2 of the training, which I'm just going to pull up very quickly, if I may. Adopt and implement a health and safety training curriculum for home care workers that is consistent with the health and safety training curriculum for such workers endorsed by CDC, NIOSH, and OSHA. So they do have specific training for home care workers. And that's why I thought we were going back to that. And that would be for the general population, not necessarily the behavioral health. If you have behavioral health, the expectation, as I had mentioned in the regs, is that it should be additional, and maybe that's somewhere where we can address some additional training there. But I think this does spell it out, and it gives us a standard. Stephen.
Thanks. I appreciate that, Tracy. Just for my own information, peace of mind, and being mindful of the fact that we only have like 17 more minutes in this meeting, we are talking about to the extent that we would create new standards, they would be to supplement sections 1 and 2 or other parts of this, not replace them, right? Obviously, if the standards we create exceed what's there, then it would replace. But we're not talking about yanking entire sections and then rewriting. Am I correct about that, or did I miss a memo?
I'll answer it first, and Sasa can chime in as well. I believe what we were looking at was to actually repeal certain sections or remove certain portions of section 1 and replacing it with that validated risk tool, if that's what the group feels is appropriate. That's why we are having this meeting. Demas did a great job in all their research and presented this as a community-based risk tool, feeling that we might be able to have more standardization. The work group requested many times some type of a standard risk tool that was validated and also had scoring that would be common across our industry, so that if it's a low, it's a low, if it's a moderate, it's a moderate, et cetera. And then the added bonus of what Demas put forward on that risk tool was that it also came with some suggested interventions, which is what in our last meeting, when we went over our recommendations, we were suggesting several best practice recommendations. So it would be removing some. Sasa and I feel that the sex offender registry is something that should probably stay on that list as our lookup. But we've all voiced significant concerns about the judicial branch. Crime-related data in the sections. I'm sorry, I'm just trying to find the judicial branch. Oh, here. Any information concerning violent acts involving the client contained in judicial records or any sex offender registry information. So sex offender registry is pretty straightforward lookup. The judicial branch was something that we had several times. We had discussed several times, and we actually had the demonstration on some of the limitations, that it did not include out of state, it did not include juveniles, it would only went back 10 years. And if we had further questions, we would have to request further information, which could take several days to a couple of weeks, is what we were told. So we were thinking that the judicial branch lookup really isn't a valid or valuable tool for us to use, which is why we thought if we looked at a risk assessment tool, any information given to us on referral, and the sex offender registry, that may give us the information we need.
Really appreciate the rundown. But so I'm correct that our changes would all be leveling up changes, not leveling down changes, basically.
Yeah, not leveling down by
Brilliant.
any
Okay.
means.
Just
I would
got
say balancing, trying to balance so that our ultimate two goals of protecting the workers and ensuring access to care are balanced properly.
Got it. Thank you. Thank you.
Sasa, did you have anything else to add to what Stephen said? I know
Yes.
we.
Yeah.
Okay.
Stephen, to answer your question, while we're doing all of what's recommended now, right? We know that the judicial, as Tracy said, it's a hard tool. It doesn't show all the individuals who had may have an impact or been impacted by the justice system. So to ensure that we have a balance of doing the checks, if we receive the information on individuals, now we're going to also add the what if. So the what if means we have all the info upon intake, right? And then now we're going in a home and we're continuing to go in. We need a risk assessment tool and we need guidance on that tool, because right now it's, do I want to just do a depression screening scale? What tool would we all use in a uniform way is what we were thinking, to assess the risk of violence, right? Or violence coming, just the risk. Then after we assess the risk, the reason why Sarah sent the steps that Demas might take after as guidance for us is, after we assess the risk, we want to make sure that across the board, we all have guidance on what to do next. So you do the risk, but do you keep sending the same staff in? Or now we have that guidance, is it going to be to call 911? Are we then going to implement having, removing just the lone staff in the home? How do we then ensure care, safety, and everything in one? And that's what we're trying to balance in home health. But there's been a lack of, larger agencies might have access, right? So to a lot of things that we can hear on this call, but the equity for the smaller agencies might not be there, and they might not have the resources to implement all of these external security teams to come in, help evaluate. They might not be able to do the big study to see which tools to use and what to do next. So to ensure that across the board, there's a minimum, I think that's where some of what Demas is doing can help guide others. So larger agencies, they can implement something at a faster rate, but we all know there's value in the smaller agencies also, and we need equity for all healthcare workers, and we need equity for all individuals who require those workers in home. So at minimum, we need a standard. We need something that we know, if DPH goes, this is what this agency is using, because we're all not communicating, we never get in a room together. So there's agencies not even represented on this committee. There's some agencies that need the guidance of this legislation and statutes to do certain things.
Appreciate the clarification. Thanks, both of you. Thank you.
Terry,
You're on mute.
Sorry about that. Thanks for the additional info. I guess I just want to make sure that I'm understanding the current recommendations that, if not are on the table, that are potentially on the table in terms of what might be changing from the original draft report. And at some point, or we did have some discussion about sort of a more centralized risk assessment portal or website. It sounds like that's no longer on the table, but let me know if I'm misunderstanding that. And that the shift is now to this review of or consideration of an agency adopting and I know we've looked at one draft, but I guess what are your thoughts in terms of the revising the recommendations regarding risk assessment, so that I can just understand it and be able to communicate it?
so I believe looking at the cost to do the repository, who would manage it, was a little prohibitive. And the last work group meeting, we talked more about, well, if we can find a validated risk tool to replace some of section 1 and have all agencies trained on it to do at certain time points, that may be helpful. And then following it with all that Sasa just said about, having some best practice recommendations for mitigating any risk that's identified through those tools, but it would be a common tool.
And then I know we talked quite a bit today about training and specifics of potential training, but are there changes on the table to that section, to the training section, or is that expected to remain pretty close to where it is?
So I think for the general population, we've talked about keeping it as is. SASA is also, I think, making some recommendations for some behavioral health training.
Thank you.
So for the purposes of today's call really was the risk assessment tool piece, and obviously it led into the training piece. What are people's thoughts about adopting a validated tool such as this? Eric?
Yeah, I would just say, as soon as Joyce Grayson's, horrible passing, we immediately put in a risk assessment tool that had different elements that are important to us and how we serve the community, so that we make sure that, and it's escalating risk. It's risk assessment. It's a risk stratification tool. So I would imagine that many agencies have done that. I will say, though, that I do think there's risk that we all have our individual tools. So because I bet our tools look very similar. That's my guess. I bet if we aggregated them all. So I would just add, while I'm kind of right now, I do appreciate my tool works for me because it satisfies all the concerns that I have. And I really appreciate having one. And I'd like that if the legislation actually has the objective of establishing best practice without a mandate me to use a specific instrument that may not best represent the people that I'm serving. So that's kind of where that's the line that I would like to see us land on. Respect that others may feel differently. Thanks.
So a mandate for best practices to be used, which would include a risk assessment tool.
Correct.
And
That's my
identification,
encouragement.
perhaps identification of one that we could put, such as.
Yes.
Versus use this one, is what you're saying.
Correct.
Eric, can you share would you mind sharing your tool with us?
Not at all.
Yeah, just so we can see, because we want to make sure that as a minimum, what would be in this risk assessment tool? So just to see the minimum.
No problem.
So
Yeah, and I know Alara Caring has one as well. I can ask if they'd be willing to share as well.
It's all the elements that we've talked about on these calls. If you're on the sex offender radar, if you have history of, if there's pets in the home, it goes well beyond violence. Pets actually escalate a risk stratification. I mean, so let's be serious. Like there's so many things beyond these governmental things that create risk for an individual being an individual in someone's home. So yes, I'll share.
Thank you, Eric. Kim?
Oh, I think John was before me,
John,
Sasa.
yeah, John was first.
John, sorry.
Thanks. So, when I look at tools like the DEMIS tool, it seems like a really good tool to do reassessments, which I think should be done on a regular basis. Obviously, the situation could change minute by minute, if not hour by hour. I have a hard time understanding, and maybe that's my lack of understand it, how it works for before one of your employees goes into the house the first time, because you have to. The way I look at that tool, like you have to go in there to do the assessment. Maybe I'm wrong, but and I think that's part of the reason for some of the things in section 1. And if the judicial lookup thing isn't the thing that's working, I think probably we should look at like, well, what were we hoping to find out from that, and is there another way to find that out? Those are just my thoughts.
Thanks, John. And I agree, the risk assessment tool, that's not an intake process. That's a risk assessment tool, but the intake process that agencies have to use now, that's something that we do separate. That's intake, and then you have the risk assessment. It's two different things. Thanks. Kim?
Yeah, I just want to offer, I appreciate the need for individualization very, very much. And I work in the Head Start world a lot, and they rewrote their regulations a number of years ago that, just to kind of summarize kind of what they mean, is that they're written in a way that says you must be able to make an argument and prove that your tool is meeting the needs of your community, violence, things in the home, and so maybe that's the way we can hit the regulation, so I'm doing little air quotes, of a best practice is to say that if you use something, you also need to say why you're using it, how it works, how it meets the needs of your community. Maybe it's based on a community assessment and for your policy of your agency. And maybe there's something that you're already doing that it can just build upon something you're already doing, but instead of mandating it, a specific tool, you're mandating that the tool you're using meets certain criteria of risk, not just, like kind of what you're saying, John, like what are the buckets, so that it does hit the dog, so that it does hit, guns in the home, but that you have a tool that captures those kinds of things. And it's based on data that your program collects, data that your program's looking at, data that you've collected in your community assessments, etc. So I am be happy to send how they kind of word it, because I think it creates so much room for individualization, but still kind of meeting a goal.
Mhm. I like a minimum standard idea, Kim, and I think that's what Eric is saying. Barbara?
Thank you, Sasa. So thank you for those comments. And the regulatory process may cover that at a high level. When we are out doing inspection activities or survey activities, we're ensuring that assessment tools, other tools that whatever the entity is across the healthcare sector, that they are in alignment with the standards of care, they're peer reviewed, and especially it's signaled if we see something that looks foreign, that's not something that's traditionally used. So the regulatory process may speak to that, but I'm going to fact check that. So, but thank you for those comments. They were very helpful.
Yeah, Barbara, I had thought that they probably did as well. So I'm hopeful when you fact check that you come out supporting your statement. Well, right at the top of the hour, does anybody have anything else? Okay, Sasa and I are going to look at everything that you've recommended, and we're going to redraft the recommendations and get them out to you. We have the other work group meeting next Thursday, hoping that we can get this finalized. We appreciate all your expertise on this call. Thank you.
Thank you. Have a good day.
Take care.